Good afternoon, everyone. My name is Vicki Ellingrod. I'm the Senior Associate Dean in the College of Pharmacy, as well as the Education Lead for the Precision Health Work Group. Today is the fifth webinar in an educational series that's designed to help clinicians and healthcare professionals understand the role of learning health sciences, artificial intelligence, and machine learning in clinical care. The overall series is called Demystifying the Data, Processes, and the Tools that are Changing Clinical Care. The series was developed in collaboration with Dr. Cornelius James from Michigan Medicine and the Precision Health Education Work Group members. The webinar series that we've conducted over the past several months is going to culminate in a half-day symposium on March 16th. Registration for this is now open, and after completion of this webinar, we'll be sending you a link and invite you to register for this in-person event, which will also have a remote option. I'm very excited to announce that our keynote speaker will be Dr. Bob Wachter, who is professor and chair of the Department of Medicine at the University of California, San Francisco. Dr. Wachter is the author of 300 articles and 6 books, and he is also known for coining the term hospitalist. He is going to address the topic of artificial intelligence in healthcare and how COVID hastens its impact on clinical care. We will also hear from U of M's own Akbar Walji, Jodlyn Platt, and Lionel Roberts as they talk about their work in regards to artificial intelligence, machine learning, and robots in healthcare. As I previously mentioned, we'll be sending you a link to register following the webinar, and we do hope that you plan on attending in person. Before we begin, I'd like to provide you with some information about precision health in case you are not familiar. Overall, precision health is focused on improving and advancing discovery, treatment, and health. Over the last 3 years, it has built new and innovative infrastructure that supports interdisciplinary research across all of U of M's campuses. I invite you to learn more about our analytics platform, some of which I'm sure will be discussed today, by going to the Precision Health webpage. There are many unique data sets that apply to many health research topics, many of which are easily accessible to clinicians. In addition to advancing research, the Precision Health Implementation Work Group has been working to integrate findings into clinical care on such hairy issues as C. diff infections, mental health, as well as COVID. Each year, we also provide opportunities to learn more about precision health through educational events, such as this one, as well as our first in the nation Precision Health Certificate Program, which is open to graduate and professional students across campus. You'll find more information about everything I just mentioned in regards to precision health, including resources, programming, and tools on our website. We also invite you to become a member of Precision Health, as we have almost 250 members now, and every member is able to use our resources, get communications to support the publication of their work, and enjoy other benefits. Today's event, though, covers an important territory that we don't hear very much about, the topic being how clinicians can access and benefit from precision health tools. You can submit your questions for our speakers at any time in the Q&A box, which is on the bottom of your Zoom screen. We're going to take a few minutes in between our 2 different speakers today, as well as at the end of the hour to address questions. So if you have any questions for our first speaker, please make sure to put those in the box when you have them and not wait until the end. Today, we are honored to welcome 2 experts who are here to share their knowledge on precision health tools and research. The first is Dr. Erin Kaleba, who is Director of the Data Office for Clinical and Translational Research at the University of Michigan Medical School. She serves as the Director of the Research Data Warehouse and Data Direct, as well as the Data Office for Clinical and Translational Research. She partners with investigators and academic departments to translate research data needs into technical solutions with an experienced team of database programmers. Dr. Kaleba is going to be speaking first. Following Dr. Kaleba will be Dr. Brahmajee Nallamothu, who is Professor of Cardiovascular Diseases and a co-director of Precision Health. His research focuses on improving the delivery and quality of specialized cardiovascular procedures across large patient populations. He uses large claims data sources and clinical registries in his research to understand optimal patterns of care delivery. In addition to serving as a co-director of Precision Health, he also directs MyCamp, which is a multidisciplinary research team that includes clinical researchers in medicine and nursing, as well as methodology experts from computer science, engineering, and statistics. And with that, again, thank you for attending, and I'm going to hand this off to our first speaker.
Thanks, Vicki. Thank you, Tina, and thank you, Precision Health, for the opportunity to present. Let me share my slides. Hopefully you can all see my slides. So yeah, on behalf of Brahmajee and myself, I really appreciate the opportunity. Vicki said it's an area that's not heard about very much, and I take full responsibility. I mean, we put a ton of effort into building these beautiful tools and resources, and then I don't do a good job of getting out there and reminding everyone that these exist. And so I'm so appreciative for something like these seminar series to be able to tell you what we've been up to. So for those of you who have used some of the data tools before or some of the services, I hope I can share with you some new data we have for you, some new functionality, all of which are really based on suggestions from you all who use the tools. We're a well-staffed group, but we're also nimble enough to be able to build new functionality, fix bugs, add new data as you suggested. So for those of you who are not familiar with some of the tools and resources, I hope you become users after today, and hopefully at Brahmajee in my next presentation, we'll be featuring you all as our success stories. So today I'm going to be talking about data, analytic platform or compute environment, and people, facilitators, who are all available to you. So the goal in general of Precision Health and of the Office of Research is really to accelerate and enhance your research with quick access to robust data, cutting edge analytic tools, and all done in the most compliant and safe way possible. So we try and be as innovative about data privacy as we are innovative about data liberation. And so you'll hear me talk about various ways in which we can provide really rich access to data, but not expose any risk to patient identifiers and things like that. So let's start with data. More than 10 years ago, the foundations of this work started on the clinical data or medical phenotype side, pulling data, amassing it into a robust data warehouse that spanned pre-MyChart and into MyChart. And simultaneously, there were efforts going on, started actually with some opioid use genetic studies that grew into the Michigan Genomics Initiative. And so these two separate projects were really brought together, and the ability to say, what does this patient's genotype say and what does their phenotype say? And that alone was revolutionary enough. With the addition of Precision Health and the specific initiative, we were able to bring those two even more together, plus more about the patient. So this was really at our core, though, these two types of data. And what I'll talk about today is how there are more than 94,000 patients. As of yesterday, 94,298 patients have consented and have trusted the university with their EMR data, with their wearables data, with their DNA, all so that we can enhance precision health, precision medicine. So specifically, the areas that we're growing into beyond just medical data out of the EMR, genetic data, is really these other areas you see on the screen. So it turns out to start discovering what keeps someone healthy, what makes someone sick, needs a lot more than data gathered in a 15-minute clinic visit or an hour or two in the emergency department. We can't tell from just those clinical data why someone's going to do well, someone's not going to do well. And so it turns out patients live in communities, they live in environments, they have family histories, they interact with social media in a way, all of these things that we know lend to someone's health and well-being, someone's sickness and illness. But harnessing those data have been traditionally very challenging. And now we're kind of like the epicenter of data collection. And so as the Precision Health Initiative gets underway, it's really trying to bring all these together. The goal is not to amass as much data as possible for the sake of data. The goal would be to really present data to you, the researchers, in a way that is transparent on how it was collected, it's linkable with other types, and then it can be converted into information. So let me dig into a couple of these on the color wheel around this patient. Let me tell you what some examples are when we say these are data available for you to use. So medical phenotype, if you think about in the electronic health record, all structured data, all drop-down menus, all order sets, things like that. So this is every vital sign taken on a patient in the intensive care, during surgery, at an outpatient visit. Medications, we have what was ordered for a patient, what was administered inpatient, and even increasingly, what was prescribed by a clinician outside of Michigan Medicine, and our patients went to pick it up at outside pharmacies, so dispensed medications. Labs, encounters can be a phone call, a month-long stay in a step-down ICU unit. All of those are encounters. Diagnosis, we have billed diagnoses, so the reason someone came in, the reason they were being treated, as well as problem history, problem summary lists, things like that. Procedures, orders, and a lot more. So I'll talk more about these, but if you don't see something on this list that you think is really important, that's what we would love to hear. So in the environmental data bucket, traditionally people would use something like zip code to say, well, I want to know about maybe some of the socioeconomic status of where this patient lives. And as you all know, zip code is a very crude, blunt way to get a handle on affluence and on disadvantage and things like that. So we undertook a great effort with our colleagues at the Institute for Social Research, ISR, and the School of Public Health to say, let's take the street address of all 4 million patients who have ever been seen in Michigan Medicine, get the latitude, longitude, associate that with the census block ID, and from there unlock national neighborhood data about that patient's environment. So this is incredibly rich. This is a much deeper look at some SES data about the patients, even things like proximity to parks, access to healthy foods, highest education level in a home. Now, it's not, if it's like Erin Kaleba is at this address, it's not data about me. It's data about the block in which I live, the average income, the average education level, according to the most recent data we have, which is often census data, but there are data collection mechanisms that are more updated than the every 10-year census. But it gives you a sense of, here's some information about the environment and what impact that may or may not have on someone's health. When we talk about behavioral and lifestyle data, this I would say is the area of the biggest explosion lately. We've had great funding and opportunity to collect wearables data, both Fitbit, Apple Watch, other biosensors that patients have. There's been studies that have looked at pain levels where someone can enter what pain level they report at the time they took their opioid, depression. There's also just incredible ways for us now to look at sleep data, activity data, things like that. I mean, we all know, like, there's data being collected now. My poor Alexa, if anyone wants to study the hot mess that is my household, you probably could do that too. So this is a really growing area. It's enormous data. And so how do we present to you in a useful way data from biosensors, data from monitors and wearables that you can use. Because as you can imagine, there is a ton of data elements. Not all are going to be useful, but this is a huge new area for us. And then genetics data, I'll talk a little bit about what's possible, but basically we have genome-wide association data on more than 60,000 patients now, some whole exome targeted sequencing. And then we have a self-serve data tool that I'll talk a little bit more about called Encore. But basically Encore will let you upload your population of interest and run association tests against other national or international reference sets. So this is for the genetic, a little bit of a drill down. So the GWAS data, you can see on the right-hand side here, the number of participants this is for. So I told you 94,000 participants have enrolled in the Michigan Genomics Initiative, have donated DNA and consented to have their data used. Our colleagues at the School of Public Health, they process the DNA in batches or in freezes. And so right now we have up to 60,000 of those 94 that have been genotyped. We'll then do another freeze and release another batch. And on this, you're going to find out as I talk that I studied Shakespeare and not genetics, but so there's on the chip that we use to analyze the SNPs, there's 600,000 variants. And then because of the brilliance of the statistical genetics group at SPH, we're able to impute up to 30 to 50 million more variants. So it's an incredibly rich set. For about 560 patients, we have whole exome sequencing available, targeted sequencing for about 1,000 patients with specific gene regions targeted. And then we have various inferences for pharmacogenetics and HLA gene alleles on that same 60,000. So if there's specific, antigen genes, or if you're looking at specific pharmacogenetic alleles, that's available also. So we work with the College of Pharmacy a lot, and they're wonderful users of these data. So then when we present these data, we give you these data, we've looked to see if your IRB allows it, here you go. We quickly learned that this amount of data, this density really needs some high compute, high throughput analytic tools that is also in a very HIPAA compliant environment. And so what's available to you is in turbo storage, and it's been HIPAA aligned. We have two analytic platforms for which you can access those data and analyze them. One is called ARMIS-2. This is Linux based. So a lot of our engineering researchers use ARMIS-2. On the other hand, there's Yottabyte, which is a Windows-based approach. So it's going to look a lot like your desktop. It's a virtual server. You go in, you access your data file, and then if you use R or Stata or SAS, it'll look like a Windows environment. And so those two are both available. Many of the data sets we provide or that you can pull yourself are de-identified. Direct identifiers have been stripped out. The dates have been shifted. However, we treat all data like they have identifiers. One, because there's no such thing as perfect de-identification, so we may have accidentally left in the data set an identifier. So that's one reason. The other reason we require all data be put on HIPAA compliant servers is that if you have clinical data and then you know enough about the neighborhood data, and you could start to triangulate. And so I really don't believe there's anything that's truly de-identified or anonymized. So we do go above and beyond in terms of security, and we require HIPAA compliant servers for these resources. So finally, I want to talk about probably the most brilliant investment from the precision health perspective, and that's the idea that with all the data and all the tools I just mentioned, knowing where to start is sometimes the most intimidating thing. And so we have actual live people research scientific facilitators we talk about, who can actually help walk you through this, who can help you start to query and see what's there, who can help see whether or not your data can be combined with other types of data. Right now, we're actually down to one scientific facilitator, Anissa Driscoll, but she's amazing. We're hiring a second one. Anissa's expecting a baby, so they say that she's really facilitating for two right now. So here's the types of expertise you can tap these facilitators for. One is regulatory. This has a ton of questions around it. What type of IRB application do I need based on what I'm trying to study? What if I'm doing something prospective? Is it exempt if it's retrospective? Do I get a waiver of consent? How do I make sure I have the right regulatory approvals around this? A second is just data. Do you have ejection fraction? Do you guys have race and ethnicity as defined by the patient? Do you have, so this is a lot of it, is just saying like, I don't want to put in an IRB application until I know that what I'm studying is actually available. So a lot of it is just like a, do you have this type thing? A ton of questions about where you can store data. Can I put this on Dropbox? Can I put this here? Can I put this on my laptop? Spoiler alert, no to the last one, but we can help with a lot of the compliance. And similarly, from a technical point of view, here's where your data are. Here's how many GPUs are available for your analysis. Here's how you can access them, things like that. Here's how you can grant access to a student you're working with, things like that. And then a lot of work's being done right now on data sharing. This was a little bit of the Wild West a couple of years ago. And so there's very clear guidance now on what's needed if you're going to share data with other academic medical centers, what's needed if you're going to share data with an industry partner, things like that. And so if you don't know, just contact the facilitators or the data office and we can walk you through all that you'll need to have in place for that. So with all of that I mentioned, all the data, all the analytic platform, the people, there's then different flavors of how you can actually access those things, access those data, let's say. So one is a self-serve access pathway. So this is kind of the DIY pathway. So for structured data, there's a self-serve tool, Data Direct. You can access that via a level 1 or a level 2 password, and we can get you access to that. You can query data for aggregate counts and for summary statistics, nothing patient level, row level without IRB. Again, feasibility analysis to say, is there even a cohort here? Are there even data here for me to go after? For some people, unlike myself, who can actually write SQL code against these relational databases, there's access to the back end, to the actual database itself, where you have secure access to join the tables and pull the data yourself. Emerse is a beautiful tool developed in-house by David Hanauer, which is searches free text, and it can bring you right to the place in the actual pathology note or discharge summary where a particular string of text or a particular word is. He's even included like synonyms and misspellings and things like that for a really efficient way to comb through notes. And then I mentioned Encore. This is that tool where you can upload your own population and then do some association tests with some large scale reference sets. If none of that works, or if the data you need are far more complex than you could pull yourself, we always have available custom data pulls that we have a team of people to do. So we right now have 5 data analysts, data scientists, SQL programmers. There's a million ways to label these wonderful people, but they basically will sit down with you, hear what you're trying to study, come up with a plan, come up with a specification, and then there's a recharge rate for the coding work itself. There's a $60 an hour recharge rate for that. We have a lot of researchers just need a one-time set of data that they're going to analyze. others need, ongoing data feeds. Every Monday, we schedule a refresh of the data output to this researcher's secure environment, and that just runs automatically. Some of the most valuable things that these analysts can do that some of the data tools aren't sophisticated enough to do is really link across disparate data sets. And so think about if there are two types of data that you'd like, brought together. That's a great use of this too. So I wanted to give a little bit of a preview of some of the things that are coming next. And then this is again where Brahmajee and I would love to hear from you all on what would be valuable, because we really can be responsive and build tools and data sets that are available to you. So one of our key things that we're working on is computable phenotypes. These are pre-calculated definitions of conditions or diseases. So if you think of definitions like how CMS defines heart failure, or what's an agreed upon definition of type 2 diabetes. So there's a set of codes, and then there's a set of criteria. So patients who have had at least 2 visits, they have, at least one of these codes, things like that. And then we do some validation testing. We get, the clinical experts to help us out. But rather, if there's a reusable definition or cohort that you're after, this is a really great way to go into a self-serve tool like DataDirect, grab your starting population, and save yourself the time of entering those 40 ICD codes, let's say. And so we have about 10 computable phenotypes or definitions now. I'd love to hear from you all. What else do you have to recreate each time? What else would you and your colleagues like to all have a shared definition on, and we can build that in. A lot of work's been done on making chest x-rays available for machine learning. So the starting place for this work was on patients suspected for COVID. So there's COVID positive and COVID negative patients and chest x-rays available for machine learning. To complement those medical images, we're now working on making the radiology report available. So we're working on de-identifying that actual report to be used in collaboration with the images themselves. So machine learning is obviously an enormous area of interest of a lot of our researchers. So again, I think next we're going to be working on brain MRIs, but if there are other types of images that you would like to see available to apply your machine learning algorithms, please let us know. So claims data, we're working a lot with some experts in IHPI around this, but we have great data if a given patient comes to Michigan Medicine for their care, but as we all know, that's not always reality. And so in my chart, data in the Care Everywhere tab, or data from other institutions that are part of a health information exchange, they are not allowable for research use. Those are only for treatment purposes of the patient. And so one way to get a full sense of the patient's utilization of the healthcare system is to look at claims data. And so we're lucky to have close relationships with CMS and with Blue Cross Blue Shield. So we're doing some work to say, how well can we match up claims data with our patients of interest? And so you'll see increasingly claims data available for your access and use. Natural language processing, we work very closely with the Learning Health System. Vinod Vidiswaran is our expert in this. And so we have a great collaboration. Brahmajee is going to talk about one example of this, but where the data office analysts will pull notes, deliver them to Vinod's secure server, and then he can run NLP on those. And then the output of the NLP, whether it be symptoms or whatever structured data comes out of that, we can then link up with what else the researcher's interested in. So it's a very powerful set of expertise we have there. We know that there's opportunity to take especially our genetic data, and really have it fully sequenced and really leverage some of the industry discoveries out there. And so I think you'll see in the next couple of months, maybe some RFPs that Michigan Medicine is putting out to see who we'd like to work with. We're very careful in our relationships with industry, but those relationships are so critical for our advancing a lot of our data in terms of doing it at scale when we don't have it in-house. So we would love to hear from you. What else? I went through that kind of quickly, but I'm going to pause and ask Vicki if there have been any questions, or if you want me to hand it to Brahmajee for his section.
We have a few questions. Thanks for asking. There was a question about are the data available to anyone working at Michigan Medicine?
So that's a great question. The data are available for a cohort, an aggregate count look. So anyone with Pierce training, level 2 access, all of that can today use Data Direct to interrogate the data and get aggregate counts back. To get data at a row level, at a patient level, more granular data, IRB is required. And so we can help walk you through what's available. I mean, what's required, sorry.
Yep, and a follow-up to that is how to get the self-help data access to the database for people who can write query codes. And I did chat the link to the self-service data tools, but I wasn't sure if there was anything else that I was missing.
We do have a request process for direct access to the database. And right now, if someone wants to just email me directly, I can get them direct access. I can put them get them the approval process started.
Okay. And then one last question about wearables, and do they catch or record depression or anxiety data?
Right, and yeah, Brahmajee might be able to speak to this better than I can, but one of our Precision Health funded pilot studies that Srijan Sen is doing is targeting patients who are coming in for their first appointment to psychiatry or to internal medicine for specifically anxiety and depression symptoms. And often there's a long wait for that first appointment. And so the wearables for patients who are in the study are to pick up both mood as well as use of mindfulness apps on your phone, things like that. But there's a way for patients who are enrolled to put in some of their depression and their anxiety symptoms. We also have data that's collected clinically. There's a GAD survey that's anxiety, and then we have the depression PHQ-2 and PHQ-9 available. But yeah, the wearables is really where someone's able to, in real time, in their real life, report symptoms of depression and anxiety.
Great, thank you. So we've had two other questions come in, but in the interest of time, I'm going to move on to Brahmajee and maybe ask you to type answers to the questions that have come in. One's in the Q&A and one is in the chat. Perfect. If you'd be willing to do that. Great, absolutely. Thank you.
Yep.
All right. Can you guys see my screen?
We can, thank you.
Excellent. Let me go ahead and start this up. So I'm going to run through this a little bit quick because I do want to get to any more questions that might be happening. But, you know, I've got the fun part of this talk, which is I get to pick 3 examples from really wonderful researchers here on campus and how they've successfully applied many of the tools and data sources that Erin kind of did a great job of walking us through. You know, in terms of how to select these 3, it was really tough. We've got a number of wonderful examples that exist out there. I tried to pick these really targeting kind of 3 areas, right? So they're diverse topics. They use a diverse set of data sources. And they really have diverse research teams that are all led by pretty successful, actually very successful clinician researchers. And they represent Michigan Medicine. They represent clinical psychology, and they also represent a research team at the College of Pharmacy. So I think it's a great way of kind of overall taking a look at what's possible. So just to dive in then, the three examples, really do go through the different aspects of the data sources, again, that Erin had talked about. The first one, we'll talk about EHR and structured data. The second is EHR and then structured and unstructured data, and in particular, looking a little bit at the tool around NLP. And then finally, I'm going to give an example around EHR and some MGI-related genomics data. They're also going in a way in an order of like going from a paper example to one in which grant funding was successfully achieved, and to one in which I think there's been a really vibrant entire kind of research program built around. So the first example is a paper from a year ago. This is by Mike Schoding, as well as his colleagues, which included Tom Valley, Stephen Gay, Jack Awashinaw, really a great team. And this paper was published as a research letter in the New England Journal of Medicine, very high impact journal. And the essential question was around whether or not our use of pulse oximetry, which is a non-invasive way of collecting data on oxygen saturation, matched up with more invasive measurements from blood samples. Now, this question is a great question. It was kind of brought up because of the COVID-19 pandemic and the sudden increase in the use of pulse oximetry, as well as the more fine-tuned arterial blood gas measurements. And one of the questions that's been a long-standing issue is whether or not, because of the use of these non-invasive tools of the pulse oximeter, whether there's a bias in how it's collected across different types of skin colors. So, this is a wonderful example of how these investigators were able to rapidly use the data sources we have at Michigan Medicine to answer this really important and fundamental issue. So rather quickly, they were able to design a retrospective study that used routine data that was collected as part of the EHR. And again, it's because of the hard work of Erin's office and team at the RDW and the exposure through Precision Health that they could do this. So they essentially had every measurement that's recorded on a pulse oximeter, the non-invasive one, as well as within 10 minutes, a arterial blood gas measurement. And they were able to do this across different types of individuals, and they limited their sample to white and black patients, self-identified, who were hospitalized during the early period of 2020. What was really exciting was that they were able to take this and then also link it to outcomes as well. But what I'll show you here is this wonderful figure that came from their paper. And what you can see here in a fundamental way is that you have these kind of teal bars and then the red bars. And over here is arterial oxygen saturation that's measured by actual blood draw. And on the x-axis is the oxygen saturation estimated by the non-invasive pulse oximetry. And what's happening is there's actually a difference in the measurement with the gold standard versus this pulse oximetry. And it seems to differ between white patients and black patients, with black patients consistently having a lower gold standard measurement when compared to pulse oximetry. Again, suggesting that pulse oximetry is overestimating arterial saturation. Now, this actually translated into pretty meaningful differences. Now, the pulse oximetry is always going to be imperfect, but what's interesting is that when you use a threshold, as you do in this case, of less than 88% being the standard, about 3.6% of white patients, both in unadjusted and adjusted analyses, were underestimated. So there were mistakes made in about 3.6% of white patients. But in black patients, that number was threefold higher, at about 11.7% and 11.4%. Now, this study is really exciting because of the impact it's had on the field, because what it suggests is that we were undertreating potentially black patients, and even might have been one of the explanations behind why we started to see some healthcare disparities in outcomes around COVID-19. And this study has been adopted now. It's been cited in by legislators, both here in the United States and then even in the UK. There's discussion about how to take these findings and incorporate them along with another body of literature into actual policy recommendations and changes that the FDA will be using to advise on the development of devices. So this was exciting to see and really impactful. So I'm going to go on to example number 2. This is an example by Ann Fernandez, who is a licensed clinical psychologist, but also a professor, assistant professor here in the Department of Psychiatry. And this is an example of how Ann was able to use some of these tools to really start to develop a new research program that's exciting, and it's actually received some extramural funding. And this is just a screenshot of her notice of award. So what Ann is interested in is we have all this rich EHR data, but the question is can we use this rich EHR data to create, as Erin had alluded to, some ideas around computable phenotypes? Like, how can you take these data to make them into meaningful inferences about how a patient might be labeled? And what they were interested in looking at is the issue of risky alcohol use, which can be a risk factor for complicated surgeries. So if they are not able to identify a patient who has risky alcohol use, then that could affect a surgical care episode. And so even though there's a lot of hope for using NLP and other machine learning-based tools, there really haven't been any adopted in this situation. So Ann went ahead and actually was very interested in thinking about how we could take the notes themselves. So not just the structured elements, it's very difficult to understand people who have risky alcohol behavior just from ICD-9, ICD-10 claim codes. So she thought that she could kind of discover this within the context of clinical notes, which can be unstructured. And again, using tools to try to understand and develop annotation around whether or not there was evidence of alcohol related use. She was able to work with a partner, Vinod Vijayasaran, and was creating this NLP algorithm. And then within, using the data again, the precision health data sources, she created a test set and was able to carefully annotate these, develop the NLP algorithm, and then test it against these gold labels, and showed some really preliminary results that were very exciting. Was able to apply this NLP on our full data set of patients undergoing surgical procedures, and then was able to discover that this outperformed when we just used ICD codes alone. So she has turned this into a R21 now, with the hope of actually being able to understand this topic even further. So in the R21, they are going to try to think about how to build on this precision health funded work. They want to validate it in a larger data set, and then also look at the validity with other markers of alcohol use. And then eventually, they want to be able to create a computable phenotype that will incorporate both the unstructured clinical notes and then the structured data from the EHRs, and really be able to create classes of individuals in terms of alcohol use risk for surgical procedures and other types of treatments. So this is very exciting work, and again, it kind of explains a little bit of a different way in which the EHR records could be used. All right, the final example I'm going to give you is around some of the work in pharmacogenetics that have been done, and this has been done by a broad team at the College of Pharmacy. I think what's really exciting about this is this really leverages some of the data that Erin had mentioned about the MGI cohort, and in particular, she had mentioned that there was the development of some aggregate data around pharmacogenomic profiles, the star alleles, which allow for much more rapid use of these data and more effective correlations with clinical outcomes and uses. So, I'm going to just hit a couple of examples of some of the work from this team. This is one set of work about just trying to understand broadly within the MGI cohort how many individuals actually have clinically actionable pharmacogenetic prescriptions within Michigan Medicine. So how many people have these star alleles that might suggest that they might not metabolize a particular drug in an ideal manner, and trying to understand how many of those people have this, and then how many of them are actually prescribed these types of medications. And by again creating this pipeline where they could look across a large number of individuals, they can try to figure out X number of people are prescribed this particular agent, and yet they might have a pharmacogenetic profile that could be less than ideal for that particular medication. And so, these data, I'm happy to share these slides and stuff, but this is from, great work that they've done. And again, what's exciting about this is to be able to do it across a wide spectrum of different types of agents. A more granular example of the work done by this team is work led by Dan Hertz, who is one of the members. Dan has been very interested in looking at how the metabolism of a particular chemotherapeutic agent, 5-FU, as well as some of the prodrugs associated with that, are used. It turns out that there is a pharmacogenomic profile around called DPYD, which actually diminishes the breakdown of 5-FU and can lead to excess toxicity with it. And due to that, it's important to identify these individuals prior to receiving this chemotherapeutic agent. So what Dan and his group was able to do was to look within the MGI cohort and do a couple of things. One is they found the number of individuals who received 5-FU who did have a DPYD variant that would affect the concentration of 5-FU and potentially lead to chemotoxicity. And in addition to kind of finding out the overall number of individuals with this, they were actually able to very interestingly use the records in the EHR to understand how many of these individuals actually did have a major event with it, either a composite endpoint, grade 3 toxicity, or the need for a treatment modification due to potentially 5-FU toxicity. So this is a much more granular example again of tying a pharmacogenomic star allele to a actual kind of clinical impact. So I'm going to stop there. I'm sorry I rushed through a little bit of that, but I did want to leave time for questions. I think, hopefully these give you a little bit more of a concrete example of what you can do and what's possible within kind of the resources we've been able to create here as part of the Precision Health program. So thanks, Vicki.
Great. Thank you so much. Those are wonderful presentations and excellent examples of some of the great work that you can do with resources provided by Precision Health. I think, I'm wondering we don't have any questions right now, so if people have any questions, but as I was kind of listening with your presentation, I can imagine that you both are really amazing people and a whole lot of information, right? And so what would be your advice to someone who is maybe interested in dipping their toe in, or maybe they have some burning question that they've seen in practice and they want to start understanding how to start answering those questions? What would be your piece of advice?
Well, I think, Erin, do you want to start? I think that the self-service tool that's been developed is a great low barrier way, but Erin, do you want to comment? And then I'm happy to jump in.
Yeah, I agree with that. I mean, I think one of the things I didn't explicitly call out was that one of the services we provide is consultation, and you could quickly find out what someone's doing and get them on the right path to the resources they need. And so on the data office website, we have a portal where you can put in a question. We respond to you that day, but And we pull in experts in whichever area you are interested in diving deeper. But I think that's one of the most valuable things. It's like that research scientific facilitator, but to have an actual person that you can bounce ideas off of and real quickly get what you need, I think that's what I would recommend.
And I think too, Brahmajee, I'll wait for you to, I'm just going to say something before you answer, but I think that too, if you're looking for a collaborator or trying to understand who might have similar interests, is a reason to make sure that you're joining Precision Health, because then you would get all the information sent out to you on a regular basis. So you would understand, because there might be a team doing very similar sorts of research, and very happy to have you join that team, or maybe you would be a different aspect of their research program. Brahmajee, did you have something to add to that?
No, I think you're right. I think a key thing is I hope everyone that's on this is a part of Precision Health. We've spent a lot of time trying to build up some of the online resources and instructional kind of videos around that, about how to get involved. I think that Erin's absolutely right, though. I think there's just so much. And it can be intimidating, but if you reach out, the scientific facilitators also have played a big role in terms of getting our message out. I think one of the strange things to me is always that, like, we can never match when you need it, right? Like, so people will have a moment, and I hope you just kind of remember that Precision Health is out there as a data resource. So when you start to develop an idea, to start with this, we probably won't solve everything, but one of our primary objectives was that we felt like Michigan medicine data was in some ways, too locked in. Too much expertise was required, and our primary goal is to try to get people who are typically not using Michigan medicine data to be able to have access to it in a much better way, but then also maintain that safety and security.
Yeah, and I think too, the tools have evolved over the years from being way more user-friendly, or not being as more user-friendly, to being way more user-friendly now. Because I know when I first heard about Data Direct, I went in there and was completely unable to find what it was that I'm looking for, and now don't really have that issue. There is a question though about what's the usual timeline from a data request with an IRB already approved to actually having data in hand.
Oh, that's a great question. So I mentioned we have 5 analysts, and that's recent. The demand for data requests has just steadily gone up, and the complexity of each request seems to also have gone up. So I was very lucky to hire up to 5 now data analysts to help with that. For the easy to medium requests, which I'm going to say are less than 50 hours of programming work, it will take about a month, maybe, by the time from when you sit down and start to spec it out now to the data in hand. If once it goes over 50 hours, it may or may not add another week or 2 onto that as it gets much more complex. But once you get over 70, 80 hours of programming time, that stretches out. Now you get data along the way often so that you can make sure that we're on the right track, or if we need to pivot a little bit in what you're receiving. So it's not like you don't hear from anyone for 2 months, but it's a back and forth. The final product for some of those complex ones is probably up to 2 months.
Great. We don't have any other questions right now. So if anyone has any other questions that they would like to have answered, please feel free to put in the Q&A or within the chat. You also might want to check out during when Brahmajee was speaking, Erin was adding some information into the chat box around the availability of data, as well as where you can submit a request for more information. And then there was also a question about the dementia being a phenotype. I also want to put a plug in for the eMERSE, using that as a tool. I know we've used that within pharmacy, especially, and that has been really useful when we started looking at pharmacogenomics, because that was a test that often it was kind of a send out test. And so if you're looking for something that's not directly part of my chart, or like a field in my chart, it allows you to get an idea of how that information is being ordered or used. And so that's a really great resource to use as well. Says, here's a comment, Erin has awesome data analysts. We're very fortunate to have this resource, and I completely agree with that.
I pay Mark well to say those things in public.
And I think we have one last question here. Is there any research into using precision health to identify patients who are at risk for psychiatric decompensation, such as suicidality or homicidality? Do we have those tools right now within precision health? I know that psychiatry has, there's screening that patients undergo when they come into the clinic. Mm-hmm. And that's kind of what the prompt study is building off of, the fact that they do the screening and they're kind of moving that into the waiting period. But do you know of other?
I know, yeah, this is one of those uses of either EMERS or NLP, because again, what makes it to an ICD-10 code can be an underrepresentation of what is actually discussed in. And so I know there's a couple of researchers who are using the text to find suicide attempt, suicide ideation, and kind of class those differently so they can see how they were managed differently. And so if someone is interested in being put in touch with those researchers who are trying to do that, because they're finding the richest information is, of course, the free text about those psychiatric illnesses.
The other thing too to remember is that our family medicine clinics here do a really great job of doing an assessment related to mental health for everyone that comes in. And so that information would also be available within the EHR as well. So I think that the data might be there. We're just looking for the right team to come along and ask the right questions and take a look at that.
Yeah, and one thing, I know it's a little bit different, but it is something that Erin had mentioned, I forgot to say, but the prompt data, which we funded, right now the PIs, Amy Bonnert and Surgeon Center, trying to create a shareable data source that will also be up on the Precision Health site. And I know, Vicki, you've mentioned it too. This is enormously valuable as a resource for us to look at around mental health issues. And honestly, it was collected just in the last year or two, when that's become a very big thing with the COVID-19 pandemic. It's a pretty unique cohort, and hopefully will help us learn a lot about how to take care of this important issue.
Yep, I completely agree. And with that, I think we are at time. I want to thank everyone for joining us today, as well as thanking our two presenters. I also really want to give a big shout out to Tina Krazier, who is our staff lead for education work group here, and none of this would happen without her working in the background. About a week after today, we'll be sending you a link that will have the recorded webinar, so you can go back and take a look at that again, as well as information about our symposium that's coming up. And feel free to share the recorded webinar link with whoever you think might be interested. So thank you all for your time, and I hope to see you in March. Bye-bye.